Hello everybody, and welcome to this week's lecture where we're going to be discussing therapy. Why do people seek therapy? Be it because of a stressful current life circumstance, be it reluctant and enter therapy at the request of a physician, spouse, or other, or to seek personal growth. Okay, so could be a request from a physician, that makes sense. Could be trying to deal with a stressful event or loss of a loved one, something like that. But also for seeking personal growth. This is a key component of therapy. Just to be all that you can be, to be a better person. You're not suffering from a mental disorder, but you want to know how to interact with people better or increase your relationships, things like that. So who provides these services? Well, there are many different people that provide them. It could be physicians, it could be clergy, but for the most part, we're looking at other people, such as the mental health professionals. And here we're talking about clinical psychologists, we're talking about marriage and family therapists, that's the MFTs. You're looking at psychiatrists. Now remember that psychiatrists are going to be medical doctors. So psychologists, clinical psychologists are individuals with a doctorate degree in clinical psychology, but a psychiatrist is somebody who has a medical degree and then they have specialized in psychiatry. And then there's also psychiatric social workers, and these individuals will probably be at a master's level as well. Okay? So the therapeutic relationship, some qualities that we see here. The client's motivation to change. The one thing that these therapists will always tell you is that, the individual has to do the work. They have to want to change. Right? Client's expectation of receiving help. A safe environment is very key here, and then a good match between the client and therapist. And that's where the therapeutic relationship is very, very important. That therapist has to, in their mind, know that they can help this individual. Okay? If they don't believe that they can help this individual, there's just not their area of expertise, then it's not going to be a good match, and it's probably not going to be very effective. So how do we measure success? This is an interesting topic here. So it says objectifying, using numbers, quantifying also, evidence-based success. And one thing that you can do is these different inventories. So these would be clients' reports of changes, like the Beck Depression Inventory would be one of those. You could do the clinician's ratings that change has occurred, so that would be coming directly from the clinician in their notes, so on. Reports from the client's family or friends. Okay? So you could, because the client might not notice that they're getting better, or in some cases if they're getting worse in whatever situation that they're in, but their family might be seeing gains, right, that the client is not. Comparison of pre and post treatment, and these can be scores on personality tests and so on. That's a good measuring tool. And then also through biological means. So we can actually do a pre and post functional MRI to look at how the brain is actually changing over time. Okay, here's your e-lecture topic item. Please fill this out along with your discussion thread and submit it for this week. Thank you. Okay, now a question that always comes up is that would change occur anyway? Remember, we just mentioned that one of the key components for the success in therapy is that the individual, the client, has to want to change. They have to have that desire to change. So if they have that desire to change, would they just change on their own anyways? Maybe it would take a while, but would they change? And some studies have been done that is actually true, that the individual may improve over time on their own. The key thing here is that, as you see in the middle of the screen, psychotherapy can accelerate the improvement. So that's what we're looking at here, is psychotherapy accelerating the improvement of their issue that they have. Now, definitely therapy can be harmful as well. Some clients are harmed by encounters with psychotherapists. 5 to 10% deteriorate during their treatment. And so that's why it very much falls on the responsibility of the therapist, and as I mentioned before, to make sure that they're a good fit, to make sure that the therapist identifies the issues, has knowledge of the issues, so that they can help this individual. Okay. So therapeutic approaches, there's many of these. Evidence-based treatment, there's medication or psychotherapy, and then there's combined treatments. I think for the most part, people are going to believe in an eclectic view. They're going to believe in combining treatment. Medication has its purposes, but so does psychotherapy, and the best result is combining the two together. Okay. So efficacy here, empirically supported treatment, determined via randomized clinical trials in which therapy is compared to placebos, and the double-blind method. So what they're saying here is that if they use the double-blind method, which means that the client and the experimenter, or the participant and the experimenter, don't know who is in the control group, who is in the experimental group. Okay, so they use that approach. They also use randomized clinical trials. They use placebo groups, and so they're really employing the true experimental design. And that's why it's saying here empirically supported. They're looking at these issues now from a very, very strict research design methodology to try to make sure that whenever they're manipulating something, which we call the independent variable, whenever they're manipulating that, maybe it's treatment type or something, that the dependent variable, which might be success for that client or improvement in their area, that might be the dependent variable. Then what they're saying is that if we create these control measures here, like the experimental group and the control group and so on, then we're more assured that what is happening, that benefit that we see in the client, the change in the dependent variable is only due to the manipulation of the independent variable or the therapy type. Okay. So again, this goes back to medication or psychotherapy. Psychopharmacology has allowed many to remain unhospitalized, which is a good thing. Include problems with side effects in matching drug and drug dosage. So there is, to any kind of a drug like this, especially those that are psychoactive, they pass the blood-brain barrier, and so they have their effects on the brain. There are going to be contraindications or side effects. And then finally, may reduce symptoms but not cure the disorder. And that's true for a lot of these drugs, but that's true for a lot of medications that we take anyways. We have a virus and we take some cold medicine. The cold medicine is helping the symptoms. It is not curing the disease itself. Okay, so combining the two, in clinical practice, we have medication and psychotherapy, which is combined, especially when we're talking about schizophrenia or bipolar disorder. And then effectiveness. Combined treatment often works better for chronic or recurrent depression. In most approaches, most treatment protocols, you're going to see a combination of the two. Some kind of a medication, some kind of a psychoactive ingredient, as well as psychotherapy. Well, what about behavior therapy? This includes direct and active treatment. It recognizes the primacy of behavior, which means it's looking at the root the root cause of the behavior, acknowledges the role of learning, and you can go into other things here like modeling, viewing others around you, and maybe they're suffering from the same disorder, your parents suffer from the same disorder. That's all like a learning or environmental issue, and then includes thorough assessment and evaluation. Okay, there's several approaches to behavior therapy, such as exposure therapy, aversion therapy, modeling, systematic reinforcement. There's token economies. Token economies are those in which if you do something that is positive, then you get a reward for it. And if you save up the small awards, then you're able to buy a larger reward. Okay, basically, aversion therapy. We're familiar with some of those, and that would be the in the case of like substance abuse or something like that, where a drug is provided so that if you come in contact with that drug, you become very, very sick. Okay. Also, some characteristics for these, they're relatively brief behavior therapy. It's directed towards a specific symptom. It's best used with problems that are not pervasive or vaguely defined, and often used with anxiety disorders or psychosis. So the interesting thing about behavior therapy is that it's going to be different than your psychoanalytic therapy or something like that, where they go back to childhood and try to find out, what was the root issue here. Okay. Here with, and sometimes that psychoanalytic therapy takes years and years and years. Here we're looking at relatively brief because we're looking at the specific symptoms. When you come in, the client comes in and that symptom is identified and they start working on that symptom right away. So it's not a problem that's vaguely defined. It's a problem that's very well known. Okay, and so that's why it works fairly well with anxiety disorders or phobias or something like that, right? Okay, we also have cognitive behavioral therapy, attempts to change behavior by modifying self-statements. Here we talk about the cognitive restructuring. We know that cognitive processes influence emotions, motivation, and behavior. So the idea here is to change those self-statements, change the way that the individual sees themselves, change the way that they believe that others see them also, because they don't really know that. That's just what they believe, and it's this thought pattern, a very negative thought pattern. One specific type of cognitive behavioral therapy is rational emotive behavior therapy, and this tries to change a client's maladaptive thought processes that influence maladaptive emotional responses and behavior. So what we just mentioned, to increase an individual's feelings of self-worth and clear the way for self-actualization by removing the false beliefs. Okay. Efficacy here, well, it's well documented with depression, anxiety disorders, conduct disorder, and bulimia. So we have very good evidence that cognitive therapy is effective for bulimia and conduct disorders, anxiety disorders, and depression. So it's a very effective tool. There is also couple therapy. This is short-term as well, based on the social learning model. Teaches partners caring behaviors and conflict resolution through better communication and problem-solving skills. So this can be very important. Remember also through these mental disorders that social support is key, and that social support could come from their physicians. We kind of talked about that. It can come from their therapist. It can come from, now what we're looking at here, their spouse or significant other, and then we're going to talk about family. All those, right, are different structures in the social support system. So here's family therapy. Within family, behavior of any particular family member is influenced by behaviors and communications of other family members. and they have structural family therapy they work with. Okay, I think you've probably heard me use the term eclectic, and here we're going to be discussing a little bit more in detail. What it means is that these therapists, these psychiatrists, they might be borrowing or combining several techniques to help the individual. They try to take what they discover in the research area, what's most beneficial for this mental disorder, and they can kind of pick and choose. Normally there is an eclectic approach, a combination of techniques. And then interpersonal therapy focuses on changing current relationships to reduce depression. So we talked about the family, we talked about the spouse, we talked about other types of therapy. This is interpersonal therapy. This is one-on-one therapy with a therapist, and focusing on changing current relationships in that way. Okay, biological approaches to treatment. There's going to be the antipsychotic drugs, primarily for your schizophrenias. The antidepressants, which are kind of used all over the different spectrum for anxiety, for depression. Anti-anxiety drugs for anxiety. Lithium, primarily going to be for bipolar disorder, but there's also other mood stabilizing drugs. Electroconvulsive therapy can be used, and the magnetic therapy as well, and then finally neurosurgery. And we're going to talk about each one of these in a little bit more detail right now. So antipsychotic drugs are used to treat psychotic disorders. Again, the schizophrenias would be in here, or the psychotic mood disorders. These are very powerful drugs, okay? And they are also listed as a psychoactive drug. They pass the blood-brain barrier, and they have their effect on the brain. There are also atypical antipsychotic drugs. They have a lower risk of side effects, and they treat positive and negative symptoms in the case of schizophrenia. Okay, your antidepressant drugs. These are going to be primarily working on serotonin. So if we backtrack just a little bit, the antipsychotic drugs, the older ones focus mostly on dopamine. Some of the newer ones now focus on serotonin. The antidepressants primarily work on serotonin. So you have the most widely prescribed and the newer types of antidepressants are the selective serotonin reuptake inhibitors, the SSRIs. The older antidepressants worked on monoamine oxidase inhibitors, tricyclics, etc. So they still, the idea was to increase the serotonin levels, but for the older antidepressants, they weren't as specific to serotonin, and they had many side effects. Anti-anxiety drugs, here's where you're going to have your benzodiazepines, and then a specific anti-anxiety drug, buspirone, is oftentimes used. Here is the lithium, very effective in treating bipolar disorder. And then there's other mood stabilizing drugs as well, like Tegretol and Depakote. Again, these are very strong mood stabilizing drugs, though. And oftentimes people who are taking something like Depakote, they feel like they're kind of always in a fog because the mental processing is just being slowed down very much. Non-medical treatment here. Electroconvulsive therapy. It is used to treat severe mood disorders. What they actually do is place electrodes on, most of the time it's done bilaterally, but like at the bottom there it says bilateral and unilateral. But the electrodes are placed one on each side of the brain or hemisphere of the brain, and then electrical current is passed through them. But it is safe, it's effective, especially in the case of depression, and often used after others have failed. So it's not going to be the first mode of treatment, but if the individual has ruminating thoughts, they can't stop these thoughts, and the clinicians, the doctors, they need some time with the client before the medication takes effect. This might be the greatest option for them. There's also transcranial magnetic stimulation. It is doing something very similar to ECT, but because you see there, it creates an electrical field that increases or decreases neuronal activity, but there are fewer and less severe side effects to ECT. The one thing with ECT is that it does have a tendency to decrease or eliminate short-term memory. Okay, and we're not going to go into the biology of that, but that would have been one of the side effects. Where here it's not as powerful, and it's not doing that to the same extent. Okay, and then finally we have neurosurgery, and neurosurgery is decreased with the use of antipsychotic drugs, thank goodness, because these are going to be very, very invasive treatments. So the antipsychotic medication has helped us a lot that way. But neurosurgery is still effective with debilitating OCD. These are the individuals that they can't function in their life because they're constantly checking things, moving things, because they have those obsessions and compulsions. Self-mutilation, anorexia. Anorexia, remember, is a very, very hard disorder to work with, and the outcome is not very, very good. And this can include deep brain stimulation, but what we mean here is that electrodes have to be placed into the brain, which means you're drilling a hole in the skull, placing that cannula down into the areas of the brain, and then affecting the brain itself. So you can see how it would be much more invasive than the other techniques, also possibly causing other issues or having negative side effects. And that is it for this lecture. Thank you.